In this session, we'll be hearing from a range of allied health professionals about teamwork in stroke rehabilitation, the role of the multidisciplinary team. Our first speaker is Dr. Sumitha Gounden, who is a rehab specialist from Orange in New South Wales. Dr. Gounden will be joining us remotely from Orange to discuss the role of the rehab specialist in the multidisciplinary team. We are thrilled to have someone coming in online to give us a rural perspective of stroke rehabilitation. Welcome, Dr. Gounden.
Thank you. So, hello everyone. A warm welcome from the cold Orange. I was asked to present on teamwork in stroke, and teamwork in stroke is it's a basic bread and butter for rehab, and it's such a basic necessity. When I was asked to talk about it, I was quite thrilled, and especially working in regional, rural area, without teamwork, we cannot survive. So it was a perfect topic for me. So yeah. Okay. So this is Western New South Wales. Local health districts has a population of 277,000 people, and 11% are Aboriginal. And Orange is right here beyond the Blue Mountains, if anyone want to know where Orange is. And now Orange is one of the regional unit where there is rehab unit and stroke unit. We also have one in Dubbo and also another one in Bathurst. Now Orange, though it has only about 41,000 population, it caters for about up to 200 kilometers. So it varies. We do overlap with Bathurst a bit and a bit with Dubbo patients as well. Sorry, click share. Sorry, it's just, okay. Now this is Orange Health Service, the Bloomfield campus. It was built about 11 years ago, and it's still looking pretty good. And Orange has 4 seasons. So winter is pretty bad. We are in winter, and the autumn is the best. You can see the colors, and okay, and that's our spring and summer. So do visit Orange. It's a very beautiful place and wine growing region. And this is my house in the last winter. I wasn't able to get out of the house. It's not a scene from Canada. It's a picture that I took from my camera. I had to get my neighbor's truck to get me out of home because the car's all submerged there. It does get very, very cold. Okay. So teamwork. Now, rehabilitation medicine by its very nature is built on the principles of teamwork and collaboration. And its goal is to enable a person with disability to return to his or own community successfully. Now, stroke being a multi-system disease, we will need multiple specialties working towards the common good of the patient and creating an individualized stroke rehab program to cater for his or her needs. Now, I wrote this common good for the patient is, now, we all want to do good by the patient. And though sometimes patient might not like what we are doing and they would have their own ideas, and some of them don't have insights. So we try and have a patient goal meeting where we will sit and ask the patient what exactly they would like to do. And we also have very regular family conferences with the family when the patient initially come into the unit and when they get discharged. And patient will have certain goals which will be unrealistic. We do understand, especially in regional remote regions, these patients live in about 5,000 acre property all by themselves, and they'll want to return back, and we cannot provide the services. It's going to be extremely impossible to do for certain patients. So we try to do what's best for the patient. And I won't paint a picture by saying that every patient who comes to rehab after stroke goes home, which is not the case. That's why I put working towards the common good of the patient, and definitely each and every patient are different, and so we have to create an individualized stroke rehab program based on the resources that they have. If they have very good family support, well, they can be two-person assist, we can still send them home. But if they don't have family support and they don't have enough resources, it becomes extremely tricky. I'm sorry, my ClickShare keeps move. Sorry, it's not working. Can the next slide, please? Okay. Now, Orange Rehab Service is a level 4 service, which essentially means we do look after lots of neuro patients. We also look after spinal and brain injury, but not the post-acute period. But we do have a lot of patients who come after a while from the rehab units, or come in with pressure area or other bladder bowel problems. So plus we have all the major traumas, brain injury, Parkinson's, amputee. We have about 16 beds and 1 TLU. TLU is a transitional living unit, which is very important, especially if you want to prepare patient to go back home. It's a very good progression for the patient. And we have in-reach service to acute ward and outreach service to neighboring sites. You know, where I showed the initially hub and spoke model, we have the peripheral sites, which are Kara, Parks, Forbes, Karak, Canadra, Blaney, Molong, Condobolin. So we do do a telehealth to those areas, and we have clinics, and which has been running for the last 10 years. And so we have a very good working relationship with the GPs in those areas as well. Next slide. Okay. So the stroke unit is actually co-located in the CCU, and there's about 4 beds, but it can be increased based on the number of patients we need. And then we have stroke case conference twice a week in the stroke unit, and rehab consultant has been consistently attending the stroke case conference anyway for the past 12 years, because I've been here for the last 12 years. And I always prioritize stroke patients, which really messes up our rehab waiting list. If you have a fracture neck or femur patient or a deconditioning patient who's waiting before stroke patients, if there's a stroke, I immediately bring the stroke patients in, which a lot of other consultants are not happy with me all the time. But stroke, I always feel stroke patients coming in early to rehab, our outcome will be really good for the patients. So the stroke physio is also from the rehab unit. So we have a good continuum of care, and then we follow these patients up in stroke unit. And then once they are ready, they come into the rehab. And then if they are a bit doubtful, the ones we don't know what to do, we got a very good working relationship with all of our neighboring sites. As I said, all the centers where we do outreach. And I also run clinics in quite a few of these places. I go in person and I do clinic. Therefore, we actually send the patient off to the neighboring site, and they wait there until they become a bit more ready to attend rehab. And I do telehealth and allocate a special time for these kind of patients who I send to follow them up. And if they are good and ready to participate, we bring them back. Again, we prioritize them and we bring them back in. So that way the beds are not blocked in the CCU and no one gets upset. A lot of patients will decline initially rehab because they want to be closer home, and because it's some of the places are 200 kilometers away from their hometown, they get a bit upset about staying in Orange. So we give them time, and then once we give them time, they are all right. Sometimes it takes a bit longer for them to realize that they need the rehab. So, which works fine because the allied health from that side liaises with us pretty regularly. So, and we also have a neurologist for ongoing stroke prevention workup, and we have a very good follow-up of these patients once they head to the community. Next slide, please. Okay. Now, sorry, I can't see the first bit. So, sorry. So we have to inpatient rehab. Median length of stay in acute was about 8 days. This includes days spent traveling to and from Sydney for ECR. Interestingly, of those discharged to rehabilitation, 4 had been thrombolized and 5 had ECR, and 5 had both thrombolysis and ECR. So rehab is still quite important for these patients. 25 of the 51 admitted to rehab are not from in and around Orange area. So in and around Orange means we call like Blaney, Molong, which are a little bit more closer to Orange, but 20 minutes drive. So those patients also not are called as Orange area. So 25 of them are completely from quite far, which will be about 1.5 hours or 2.5 hours away from Orange. So next slide, please. Now, these are general outpatient rehab service that we provide. So we can see a wide range of service, including our spasticity for these patients. All stroke patients need spasticity follow-up as well. So we run that, and they also have issues with your bladder and bowel. So we also have a district-wide multidisciplinary continence clinic, which I run along with the urologist. Mainly it was designed for spinal patients, but we also see stroke patients with incontinence coming to that. We also have a continence advisor who attends the clinic and follows these patients up both via in-person and also telehealth. So next slide, please. Okay, for team building, it's very important to have lots of educational workshops. And that will actually also will help promote Orange as more of an educational hub for all the allied health staff and the nurses in the district. So we run a lot of programs. Now, the musculoskeletal examination is something that I do for the rehab faculty, and Orange is quite famous for this workshop, which we've been running for 9 years. Because of COVID, 2 years, I haven't done it. All the rehab trainees come for it. We have chronic pain workshop, we have spasticity, wound management, FIM workshop, Parkinson and gait retraining workshop. Next slide, please. Yeah. Now, the collaboration and research, we have a rehabilitation clinical stream where all the 3 centers, the Dabo and Baptist, all of us join together and have a bit of a meeting once every 2 months. And we just discuss about what it's about the future, and we go through our FIM to see how each one of us are performing. Now, rehabilitation planning meeting is something is run in the unit, and we are affiliated to 2 medical schools, and we work on a district-wide tele-rehab service. Is something that I really want to set up in a bit more structured way, so every patient in the district will have access to rehab. It's still an ongoing project, which though I do the clinic, I don't have a full allied health team doing the clinic with me. So that's where I'm trying to do, especially for stroke patients. I would like this to happen, but something that I need to work on still. And we do a lot of quality assurance projects. So only in the last 2.5 years, we did about 15 posters. Before that, there's been multiple posters we put, but we can't do massive research. We're doing one spinal, but not a big research because we don't have allocated time, and because of the staffing issues, we'd really like to do, but yeah, it's something that I'm hoping to achieve in the future. Next slide, please. Okay. Now, the wall of fame is a very, very powerful weapon for the patients who come into the rehab unit. And this what we do is success stories of the patients that have triumphed over the arduous journey are displayed throughout the rehab unit to give hope to other patients and their families during the most vulnerable and difficult time of their life. So next slide, please. Okay, and then this is an Aboriginal girl who refused to get out of the bed the first 2 weeks when she came into the unit. And then she started working. Once I displayed the art that she wrote one night in a room. And this is just art that she wrote with a hand. She was quite disabled. And she said that these are the paths that she noted to go to a home, because she was about 400 kilometers away from her home. And she did really well, and she went home. Okay, next slide, please. And this is just all embracing, giving back to the community. Again, teamwork. Next slide, please. Okay, and then ward Christmas decorations. This is something is really big in our hospital, especially in the rehab unit. And all the staff get together and we do decorations, and we are extremely competitive. Rehab unit almost wins every year. You can see the amount of effort we put in. Next slide, please. And then rehab MDT games is between the physio, OT, social worker, and dietitian. We have this simple game, which a silly game for 20 minutes, once every 2 months we do, and then Barbie doll is a gift. So, and if the physio wins, is a crutches Barbie doll. If the doctors win, there's a Barbie doll with stethoscope, and OT wins Barbie doll with wheelchair. So next slide, please. And we do a blood donation campaign, a winter blood donation campaign. And towards the end of the campaign, once we save 1,000 lives, we have a get-together kind of a program. And all these are staff. You will see from ICU, doctors to the surgeons to the ED physicians, and these are all our nurses, our NUMs, our allied health staff, everybody into this. We get everybody looped into this. Next slide. Okay, services we lack, the ones, as I said, the tele-rehab service, and we don't have outpatient rehab service for the stroke, which is something that I'm working on. Next slide, please. Okay, now optimum is a choice. Rehabilitation medicine is nothing but optimism at its best. If you're willing to give it a go, make every barrier an opportunity to learn and adapt and do better. And I'm totally blessed to have chosen rehab medicine and to work in the rural setting. And this is, again, my team, and that's our social worker. Yeah, it's about team building. Thank you.
Thank you, Dr. Gounden. That was great.
Sorry for being so fast.
Next, we'll be hearing from Andrew Rock, a clinical neuropsychologist and head of department psychology at Concord Hospital. Andrew will be discussing the role of the neuropsychologist in the multidisciplinary team. Welcome, Andrew.
Thanks very much for that kind introduction and for the chance to come and share my perspective today on the role of neuropsychs in stroke rehab. So, straight off the bat, I've got a good news, bad news scenario for you. The bad news is with the use of smartphones, I think all of our ability to concentrate is getting shorter and shorter. But the good news is I've got you back. I've boiled down my whole talk, basically, into this one slide here. Going to go into more detail for you in a moment, but this is it in a nutshell. Neuropsychs try to do three things when we're working with people with strokes. The first thing we do is measure stuff. We measure different mental skills in quite a lot of detail, and the point of that is giving us really quite a detailed sense of individual strengths and weaknesses. You've got them, I've got them, we've had them always. Sometimes they're different after a stroke. We try and get a sense of what they are. And the second thing we do is we take that messy desk and that pile of numbers we've just created, and we try and get some meaning out of that. And the way we go about that.
You should use the clicker, Andrew, which is just there to move your slides on when you're ready.
Oh, sure, okay. We're learning. Okay, so we try and understand the results in context. We try and compare apples with apples. Is an apple a big fruit? Depends. You compare it to a grape, it's huge. You compare it to a watermelon, not particularly. Comparing a number with the number that everyone gets on a test, not necessarily that helpful. So we try and match people with folks of similar age, same sex, same cultural background, same education, so that the numbers actually mean something. And the third thing we do, and probably the most useful, is we try and inform decisions about the future based on what turned up in the assessment. Okay, so I'll go through briefly the sort of things we look at, the things that we reckon are potentially relevant when we're doing a neuropsych assessment. The first thing we look at is attention. And there are different facets of attention. There's your ability to take in simple information you hear just once, like a phone number. 97676550, that's my department's phone number. Can you say that back to me? Probably not. It was 8 numbers long and you only heard it once. But that's the sort of thing we might look at. The next thing we look at would be what we call working memory. Super important in getting anything done in your life. It's your ability to keep your goals active in your mind despite distractions. You go into a store wanting to buy 5 things and the cashier talks to you. When you turn back to your job, to the task at hand, can you still remember what you were trying to do? That's your working memory. The next thing we look at is selective attention. Can you ignore the stuff that doesn't matter, the stuff that's not going to help you in the task you're trying to do right now? And the last thing, divided attention. We're not the only people that look at divided attention. This slide here shows that in the States, they don't use random breath testing as much as we do. They do their own little roadside screen of using divided attention. They get someone to stand on their leg while they count from 1,000. 1,001, 1,002, 1,003, I'm sober. The guy in that picture is not. And because he's not sober, his divided attention was wonky. We test it differently, but it's the same thing we're looking at. Okay. Next thing we would look at is purely and simply how quickly you process information, because that's a pretty useful way of gauging how efficient your brain is at the moment. You can do it in different sort of ways. You might say, here's a page, I want you to cross out all of the circles on it. Or here's a page, I want you to write down a 3 for every one of the crosses you see on the page. Just how quickly can you do basic stuff? Okay, the next thing we look at in a lot of detail is memory. Memory's complicated, lots and lots of different things. We might look at, for example, your memory for words like piano. We might look at your memory for pictures, like show you a piano and then get you to show us if you remember it later. Or we might see what you can actually do. Like, for example, can you play a piano? Another thing we look at, because it's very important, is what do you like at taking in information in different formats? Probably you'll take it in much better if it's in a meaningful kind of context, like a little story, so we'd look at that. But we'd also look at how do you go getting information into memory if it's not structured, if you're the ones who have to come up with a context for it, like maybe a list of words. And we'd look at what can we do to help that memory of yours work? What do you like at coming up with that stuff spontaneously? What do you like at remembering it if I give you a little cue, like tell you some of those words were types of cars maybe? What do you like at recognising things I presented to you before? Did I show you this picture of a piano before, yes or no? So we look at the different facets of memory and what we can do to help you retrieve it. Phew, that's a relief. Next thing we look at is people's spatial abilities. Really important in rehab. We've got our own particular take on it. From our point of view, you can boil it down to 2 things. There's your ability to make spatial judgments, and there's your ability to do stuff with your hands, to understand the world around you, negotiate things in real life. So, for example, in the picture there, down the bottom, we've got a whole lot of lines radiating out, and they've got numbers, so we know which one we're talking about. And up above it, just under the writing, just under where it says perceptual, we've got some lines. So I might say, okay, which one of those lines down below is pointing the same direction as that line on the left? And which one's pointing the way as the one to the right of it? That's a way we might look at your spatial judgment. Another thing we'd look at is, what can you do with your hands? Can you make sense of the world around you and actually change it? Can you copy a picture for me? Can you reproduce patterns with blocks? Okay, we look at language, so do speeches, so do many, many people working with people with strokes, and we all have our own little perspective. We might do it informally. We might see, what's this person like at taking in, at understanding the questions I'm asking? What are they like at following the directions I'm giving? If they're simple, can they do it? If they get more complicated, can they do it? And what are they like at giving information back to me? Do they need prompts? Do they need assistance to kind of structure the story they're trying to tell back to me? Or can they do it okay themselves? Really important to know if you're trying to engage with someone. We might do other tests depending on the situation. A really common problem after stroke is coming up with the words for things. Happens to all of us sometimes, don't get freaked out. It's a universal experience each and every day, to some extent for a lot of people. Much more noticeable often after a stroke. So I might show you this picture, for example, on the top left-hand corner. Everyone, I assume, can tell me what that animal is in the top left-hand corner. You'll probably get deported if you can't tell me. Yes, sir? Bang up job. You're exactly right. And it would get harder. We might start off with that one and we'd build it up. We'd get tougher and tougher and tougher. So that one in colour, really weird looking animal. I've seen it once in my life and I didn't believe it was real. It is. It's called an okapi. We don't have them in Australia. You're unlikely to come across one. But the point is, we'd start easy and we'd get hard and we would see where on that continuum is a person falling. Another thing we might look at is, maybe a person can't come up with the words so well, but they understand what the words mean. They get the essence of that word. So, for example, we might show you a picture there like a pyramid and say, okay, which one of these 2 types of trees goes with a pyramid? Is it the Christmas tree or is it the palm tree? And most people are going to say, well, pyramids, palm trees, they go together because you find them both in the desert. We might not do that test terribly often, but it's an interesting one. It can tell us quite a lot if we do. And the last thing we'd look at is executive functions. Executive functions are kind of a complicated term. We're using it as a grab bag. It's a mix of your complicated thinking skills and your ability to control your behaviour, to organise your behaviour. So from a cognitive side, some of the things we might look at are flexibility, mental flexibility. What's a person like at jumping from topic to topic? We all get lost if the topic's just bouncing around randomly. It's effortful to do. After a stroke, often folks get less efficient at doing that. So we'd want to understand how efficient people are at that. We might look also at people's ability to solve logical sort of problems, to look at a pattern and work out what comes next in that sequence. And we might look at a person's ability to plan. What are they like? How efficient are they at solving problems? Can they do it? And how efficiently can they do it? So that's the thinking side of executive functioning. And there's also a really important side, which is organising your behaviour. One of the things we might look at is impulse control. We all have a handbrake in our heads, stops us doing the thing that we want to do straight away. The handbrake in our brain stops us doing it because it's maybe not appropriate here. So we would test impulse control, and we might test perseveration. Perseveration is a person getting stuck in a rut. Let's think, for example, about a conversation. Maybe we're talking about movies, and we all contribute a movie we liked, and then the conversation moves, and now we're talking about restaurants. But someone still brings it back to movies. Okay. Conversation moves ahead. Now we're talking about schools. Someone still brings it back to movies again. That's an example of perseveration. That's an example of sort of getting stuck in a rut mentally. And another thing we would look at would be initiation. So we talked before about the handbrake in our heads. What about the brake? What about the starter motor? What about the starter motor in our brains? What about our ability to actually initiate, to start doing things we need to? Now, this picture I've got on the right, it's not an actual test that I would use with adults. It's a test we would use with kids maybe to look at the same thing. The point of this is it's a test of impulse control. It's some of you might know the game Whack-A-Mole. This is a neuropsych test based on the game Whack-A-Mole. So you show people pictures. Sometimes you show them a mole, sometimes you show them a veggie. If you show them a mole, they've got to hit a button. If you show them a vegetable, they don't hit anything at all. They get used to hitting the button every time a picture comes up, and then you change it, and it's a vegetable, and they're not meant to go. Do they go anyway? That's an example of a way we might look at impulse control. Okay. They're the things we would test. What do we do then? We've got a messy desk, we've got a lot of numbers. What do we do now? What we do now is try and understand what it means for that particular person in that particular situation. You've got to consider culture and sex and language. Those things are really important in understanding scores. So, we've got here pictures of puppies and elephants and rhinoceros. And the point of this is, sorry, the bit I need isn't showing on the screen there. Okay. What I'm going to do now is I'm going to tell you the names for these three things in Spanish, and then I'm going to tell them to you in Vietnamese, and you tell me which one is quicker. Okay, here are the names of these three things in Spanish. El cachorro, el elefante, el rinoceronte. Forgive the pronunciation. Okay, was that quicker or slower than this? Can you, voi, tegak? Much, much quicker in Vietnamese, yeah? Just the mechanics of producing the sound makes a difference. A healthy Vietnamese person will produce roughly maybe 19 animals within a minute. A healthy Spanish person will produce maybe 14 words in a minute, not because one group's smarter, not because one group's dumber, but because they're speaking a different language. It takes longer to produce sounds in one. So you've got to consider results in context. Another thing that matters is age and education. So here's a nice way of illustrating that. They looked at people's ability to produce words in 3 different cities in the States. 2 of the cities, whoops, we've gone over time. Take my word for it, education matters. And what do we do with all that? We use it to guide decisions. We use our recommendations for OTs and speechies and physios. What are the strengths? Maybe they seem like they can't take in information, but in fact, they can give it back to you. They can show you what they're meant to be doing. Maybe they're terrible at taking in instructions in words, but you actually show them what to be doing and they can do it. We would also look at things like where the person goes from here. Can they drive? Should they be having an on-road assessment? What are the implications? Can they go back to the same role they had? Or should they maybe be looking at a different job going forward, or avocational kind of activities? And also we'd look at stuff like, do we need another pair of eyes on this? Should they be seeing a clin psych? Should they be seeing a psychiatrist? Neuropsych is useful. It's not perfect in every situation. It's really helpful for some stuff, like when there's ambiguity, when there are important questions to address. Can a person still make decisions, for example, about where they live? That's pretty important. It's a really weighty question. You want to consider it in serious detail, and neuropsych is helpful for that. It's useful for monitoring change over time, but it's not perfect. It's not useful all the time. It's not helpful, for example, if we can't match them with a test that we have. It's not useful if a person is impaired as all get out. It's just mean, making a person do really hard, long tests if they're really impaired. It's not helpful at all if a person is not willing to do it. The numbers are as meaningful as the effort that goes into it. And it's not useful if you need numbers fast. And in closing, how do you get a neuropsych? Unfortunately, the news isn't great there. It's tough. There's not a lot of neuropsychs. There aren't nearly enough. Talk to your GP. GPs tend to be well connected. Some of the options are hospitals. Most hospitals have got a neuropsych attached to them. You can go to the private sector, the Australian Psychological Society. They've got a website. They'll tell you how you might get a private neuropsychologist. And the other option a lot of people don't think of is uni clinics. Uni clinics have students under supervision offering perfectly good neuropsych assessments for less than you would pay typically. And that, in a nutshell, is my personal take on the role of neuropsychs in rehab. Thanks very much.
Thank you, Andrew. May Kwan is our next guest speaker, who is the team leader of Neurosciences Physiotherapy from Royal Prince Alfred Hospital in Sydney. May will be explaining the role of the physiotherapist in the multidisciplinary team. Welcome, May.
Thank you, Brenda. I'm about to take you to a video which is from the stroke survivor perspective of what physio actually doing for them. Before I had stroke 10 months ago, I only knew physiotherapists are working with people with back pain, teaching people exercise, or helping someone like Homer Simpson always endures accidents and injuries. I had an excellent time in my retirement, always on the road with hubby. We travel everywhere. I drove my car to meet my friends, play with my first grandson, and attend senior dancing class twice in a week. Also enjoying knitting. The darkest day of my life suddenly arrived. When I woke up in the morning, I tried to get out of my bed as usual. I eventually fell as I tried to stand up. I couldn't recall what had happened on that day. My husband told me that my speech didn't make any sense and apparently confused. Ambulance came and took me to hospital. I couldn't recall any of this. I didn't know what had happened. When my head came to senses, I was lying in a hospital bed, hooking up with monitors, half of my body paralyzed. I now know I had a blood clot in my brain. It is a stroke. I was told the cause of my stroke is due to irregular heartbeat that I never heard of or realized that I have problem in my heart until I have a stroke. As a result of the stroke, the left side of my body was paralyzed and still not fully regained all my strength today. I was so exhausted, didn't have a clear mind, and the headaches made me feel so difficult to open my eyes. I was so sleepy. However, my sleep were pretty much disturbed by many people came to my bedside doing all sorts of things. I didn't have any clue of what and why they are doing all this. Of course, now I know they are taking care of my condition at that time. I was so overwhelmed by many people, many tests, many assessments on the first few days of my hospital admissions. I met lots of healthcare workers within days. I got them all mixed up. I'm more confused. One day I fell out of bed when I tried to get up and go to the toilet by myself. After that, doctors, nurses, OT, physio, and even my hubby, they all gave me a lecture again and again and told me I should push the buzzer to ask for help. So sad and depressed. I cannot fathom it. I have been getting up from my bed by myself in a split second for more than 65 years. Why I need help for such a simple thing now? I have love-hate relationship with my physiotherapist. When I first met my physiotherapist, I couldn't distinguish who they are. As they came to me day after day, we start to know each other a bit better. I hate them. They are very good with nagging. They always work me hard, especially when I felt tired, exhausted. They still got me out of bed. They got me practice standing up, not with my way, but with their specific way. That include feet behind the knee, not allowed to use my hand, lean forward, put weight on my left leg. Why? It's so annoying. I keep on bargaining with them to stand up with my way. Gee, I still remember all these steps after many months. Definitely, their nagging slowly sank into my head. This is obviously a great training of my memory. I took a few steps on the 10 days after the stroke. I burst into tears. I was so excited and overwhelmed. I could walk. I don't need to stuck in bed or on the chair anymore. I can walk to toilet myself. I don't need to see these people every day anymore. I can go home soon. However, the first step was only the beginning of more sweat and tears in my long journey in rehabilitations. It was still a long way before I can go home with my hubby. I then transferred to rehabilitation ward. On top of all the other discipline working for my cognitions, memories, talking, and self-care. My physio are so greedy. They always tell me to do more and more. I had to do 80 sit to stand, 40 calf raise, 40 hamstring curl, 100 toes tap, 20 wall squat, standing and marching on the phone for 5 minutes, plus walking 20 minutes on one session of physio. I must be able to walk on stairs before I go home. Otherwise, I will follow the footsteps of Homer Simpson with many falls and injury. Physio also taught me to do mental practice to imagine step by step of what to do on a stair. Then I have numerous practice on wheel stairwell until the day I can manage myself safely up and down on the stair. I did it! I can go home. Home sweet home. I went home 9 weeks after my stroke. My journey with physiotherapy hasn't ended as I return home. I still have few more goals to work on. Initially, they came to my house to teach me community ambulations, more walking and on different terrains. I managed to walk outside with a stick and able to go outside by myself. I can navigate stairs without any problem as long as there is a grab rail. I do walking as exercise for 30 minutes every day. Then the home-based stroke outreach physio stopped visiting me. It turned out I visit them weekly as an outpatient. I had exercise class and one-to-one treatment to work on my balance. The journey with physiotherapists is not end in a short future. They continue to work on my balance. I wish I can trace my grandson, travel with my hubby, and hopefully I can drive again. This is my story with physiotherapists after the devastating stroke.
Okay, that's basically highlight physiotherapy is not working alone with you. Of course, you are the most important person for us to work with, but at the same time, we also collaborate with the rest of the team, working together with all different goals in different state of your rehabilitations. That's it. Any question? Okay.
Thank you, May. Kate Macroglu, did I say that right? Almost close. I tried so hard. Is a rehabilitation occupational therapist from St George Hospital. Kate will be discussing the role of an OT in the multidisciplinary team. Welcome, Kate.
Thank you, Brenda, and thank you first to Michelle and the Association for inviting me to speak today as well. I love being an OT. I'm so passionate about what we do and the privilege that it is to work so closely with patients after their stroke and be a small part of their recovery. So I'm really pleased to be here today to speak to this group, so thank you very much for having me. I'm going to speak about what an OT is, where OTs work, what we do, and touch on our role in the multidisciplinary team, though I think that's pretty clear when you hear what I'm speaking about and what all the other health professionals have spoken about today as well. So I think to understand what OT is, we need to understand how the term occupation is used in this instance, which isn't to describe work or a job, but as it says, they're skills for the job of living. So one definition I really like here is the top left, which is a form of therapy for those recuperating from physical or mental illness that encourages rehabilitation through the performance of activities required in everyday life. Some of the other keywords here are things like meaning, satisfaction, independence. So we want to enable and empower our patients to participate in life, and our therapy is focused on the things that we do in our life roles, the things that give meaning to our life, and the things that help us to engage in our wider society and our culture. So OTs complete either 4 years of undergraduate studies or 2 years of postgraduate studies, and during that time we complete around 1,000 hours of fieldwork placements as well. Registered with APRA, so to maintain that and continue to practice, we have to complete 30 hours of professional development each year. And we work across a range of settings in neurology and neurorehabilitation, some of which Sandra talked about this morning. So we work hospital-based, so in inpatient settings, acute wards, inpatient rehabilitation, day hospitals, outpatient clinics. There's community-based therapies, so the home-based programs, the stroke outreach services, and I think an evolving area of practice as well is in private practice, where we have colleagues doing a lot of work with the NGIS as well, which is a growing area. And also we have our colleagues in research and education. So that's our colleagues who contribute to the evidence base that we base our practice around. They're the people that test our interventions, and it's how we make a lot of our clinical decisions and how we know what we're doing is safe and it's effective. One way that our practice is guided as well, there's a whole range of models out there. I thought I'd use this one as an example because I really think it captures the essence of what we do. So that's the person, environment and occupation model, or who you are, where you are and what you do. And in the centre here, where all those factors overlap, it's our occupational performance. So that's where, I don't know if you can see it up there, but a person's ability to perform the required activities for their tasks and roles of living. So that's where we look at how all those factors of who you are, what you do and where you are impact the things that you do every day. So I think after having a stroke, we do need to put some more consideration into your environment, which from where I work in an inpatient setting is often looking at someone's home environment. We want to know, in terms of person, who you are, I think a lot of the changes after stroke quite broadly would fall into two categories in terms of what OTs would look at. So that might be physical changes or cognitive changes. And then also looking at the things that you need to do every day, what's meaningful to you as a person and what are the things that you enjoy doing, what are your priorities. So I'm just going to talk through some of those factors and some of the things that we would commonly do as OTs in this area. So looking at the person factors, so who you are, as I said, we want to know your occupations and your roles, what's important to you, and how are the cognitive and physical changes that you might have had after your stroke impacting the things that you do every day. So as per the stroke guidelines, everyone that comes into hospital with a stroke would have a cognitive assessment, so that commonly might be something like a mocha, which I've got pictured here. And then from a physical point of view, we're really looking a lot at the upper limb. So that might be looking at the function, the strength of the arm, looking at fine motor skills. We really use a battery of upper limb assessments as well as looking at how the arm's used in function, and then secondary complications, so how are things like pain or swelling impacting the function of the arm as well. In terms of environment, OTs are often assessing the accessibility of patients' homes and also sometimes places they might need to go into the community as well. In an inpatient setting, the assessment of the home environment is really essential as part of our discharge planning, and it's a really well-established role of OTs in most multidisciplinary teams. So our goal here is to ensure that where we're discharging our patients to is a safe and supported environment for their level of function. And we also consider not only the physical factors, but the social, cultural factors as well, things like existing and required supports, funding bodies that may be involved, and that type of thing as well. Moving on to occupations, because in OT, I think the thing that sets it apart or makes it a little bit different, especially when we look at lots of similar areas across the disciplines, is function. So everything is related back to function. So we want to know what occupations does our patient need to complete and to what level to ensure a meaningful and fulfilled life following their stroke. So OTs are trained and I think uniquely skilled in performance analysis. So we use a range of functional assessments, usually starting with basic ADL assessments like showering, toileting and dressing, and moving on to more complex tasks, whether that's cooking, accessing the community and even driving. And that's what we use to set our functional goals with our patients, and we plan and prioritise our intervention. So what tasks are important to the patient, I think, is really important, because we tend to get stuck in looking at what's available to us in the hospital. So we might look at someone being able to shower independently, but is that what's important to the person? Maybe the person's happy to have help with showering and they'd rather use the energy to go and visit their family or go on their social outings or whatever it is that they might need to do. So you want to consider what are their long-term goals, what are the things they want to achieve, and what occupations are the short-term goals or the stepping stones to help them to get there. So all of that leads us back to the centre of the model here, which is the heart of what we do, and where those three factors overlap and they determine our occupational performance. So through our analysis and a mixture of some of the other assessments that I've discussed, OTs work with patients to try and identify some of the key factors that are impacting on their occupational performance, and we then provide a range of interventions to help address some of those challenges. I think what you can't see on there that I have at the bottom of the slide is the vision statement that our department uses, which is empowering you through creativity, collaboration and choice. Thank you. Which is a vision statement that we're really proud of as a department, and we always try to uphold and work towards with our patients. So moving on to intervention, again broadly, we'll use a combination of restorative approaches and compensatory approaches in rehabilitation. So we might be doing something like cognitive retraining, where we might work on someone's ability to pay attention, multitask or divide their attention. We might work on increasing the speed of their brain to process information, or what we would call the executive functions, so being able to plan and carry out some more complex tasks as well. And those problems in those three areas are really common following any kind of injury to the brain, and they're all areas that we can work on. We'll do that with a combination. We might do some paper-based or tabletop tasks, as well as then practicing that in real-life settings, either simulated in hospital or clinics, or actually out in the community as well, to really try and improve those skills. And another area of OT intervention that is a large part of our scope of practice is upper limb retraining. So that obviously is, again, quite varied. So we have patients with little to no movement of the arm after their stroke, and we have then patients also at the other end of that spectrum with only very minor fine motor or coordination issues. So where there's not much movement, OTs might prescribe supportive devices like the shoulder brace that you can see there. We would also, at the same time, regardless of the level of function, be working on strengthening the arm, trying to improve the skills and the function of the arm as well. So we would use interventions like electrical stimulation, motion sensors, mirror boxes. We might prescribe a constraint therapy program, which is a really intense and structured program, a really well-evidenced intervention for OT, where we constrain the non-affected limb for about 6 hours of the day. And I think the important thing to remember is, although we're treating the arm, we know that the injury occurred in the brain. So we're trying to use interventions that help work on that connection between the brain and the body. So we'd also use things like that I think that May mentioned about motor imagery as well. So we're just really trying to improve that connection, laying down those neural pathways that can lead to increasing the movement of the arm. Another way that we do that is with functional task practice as well. So completing tasks using your affected arm that are things that you know that you did before, and use familiar objects and tasks to do that. And then we move on more probably to the compensatory approach when we're looking at prescription of modifications or equipment. So we particularly, after assessing someone's home environment, we might prescribe some equipment for them, and it might be something quite basic like a shower chair, or it could be something more complex like a powered wheelchair. Again, everything we're doing is tailored to the patient and back to the individual, the function and the goals of the patient. We'd also look at minor or major modifications, so it might be just something like a rail in the bathroom, all the way up to something, a fully accessible bathroom, ramps, stair lifts, etc. Another thing we consider here is seating, so prescribing wheelchairs, cushions, backrests, and sometimes quite complex seating systems as well. And then the last intervention that I wanted to talk about, but definitely not the least, is functional retraining. So that's where we really bring everything together. We put our tasks into practice. So that's when we're supporting our patients to relearn how to do activities again. And so while we're working on the factors themselves, like strengthening the arm or working on the speed of thinking, I think it means very little if there's no functional improvement. So if that doesn't help you to do the things that you need to do. So at the same time, while we're trying to work on improving the skills themselves, we're trying to put it all together in enabling people to do as much as they can in the tasks that they want to be able to do independently. So it might unfortunately happen that progress is slower than we'd hoped. So although we're working on someone's arm, we might still be teaching them how to dress themselves one-handed or how to meal prep one-handed. And that's where we'll be prescribing some small aids like the ones here. There's some long-handed dressing aids. There's a spike board that we would use in the kitchen. Or it might be more cognitive. So we might be looking at relearning how to cook and shop and plan all of that for your family now that your thinking has been impacted as well. The last thing I wanted to talk about quickly, because I have 1 minute left, is the role of OT in the multidisciplinary team. But as I said, I think that's pretty clear. You can probably see from some of the things that I've talked about today that overlap with what Sandra spoke about this morning from a nursing perspective. Obviously with psychology, a lot of our cognitive interventions overlap here as well as with speech, and with physio looking at how people move and all those person-related factors as well. And I think discharge planning is a really good example of where the team really comes together. where collaboration is key, where we work together to try and get the best outcome for our patients, but obviously with the patients at the centre of that as well. And I might stop there. Thank you. Thanks for 6 seconds.
Thank you, Kate. Our final speaker of this session is Virginia Agosti, who'll be presenting on the role of the speech pathologist in the multidisciplinary team. Virginia is the Neurological Rehabilitation Care Coordinator at Metro Rehab Sydney. Welcome, Virginia.
Okay, I'm too short to see the actual screens. So bear with me. Thank you so much to Michelle, the Association, John, Brenda, and all of you for having me here today. So I'm going to be presenting on the role of speech pathology in the multidisciplinary team, but with a focus on how we work with other team members. Firstly, I'd just like to acknowledge the traditional custodians of country and their connections to land, sea and community. I pay my respects to elders past, present and future, and extend my respect to all Aboriginal and Torres Strait Islander people present here today. So, what is a speech pathologist? Also known as a speechy, SP or speech therapist? Well, speech pathologists are health professionals, so they have a university degree. They work with stroke survivors of all ages across the whole stroke journey. Mainly, we help improve communication and swallowing. We try to provide holistic management. So we start with assessment and diagnosis, so you're testing. We work with you on goal setting and treatment, so making the improvements. We try to re-enable you and help improve wellness, so make you better able to do things and feel well in yourself. We work on education and advocacy, so things like this. And the important part is we work as part of multidisciplinary teams. So what happens after our stroke? Some communication impairments that you might have include aphasia, so that's your language difficulty that can affect listening, speaking, reading and or writing. Dysphonia, so difficulty using your voice. Dysarthria, so difficulty using the speech muscles to make sounds or words, the slurring that some of you may have had with your stroke. Dyspraxia, so that's difficulty planning the movements for speech. Or a cognitive communication impairment, so that's where you have difficulty with both thinking and language together. Now, the treatment really includes exercises, communication partner training, so bringing other people in, and then augmentative and alternative communication systems if we can't return completely to speech. We also deal with swallowing impairment, so also called dysphagia. Now, it can affect different parts of the swallow, so from before you get the food and drink into your mouth, in the throat, and then down into the food pipe, the esophagus. So what speech pathologists do is we can recommend softer foods, thicker drinks, and maybe strategies to keep you safe. But we don't work by ourselves. Definitely not. We work in multidisciplinary teams. And so you can see Yasmin here in the centre of our team. We've got the doctors, the friends, our allied health professionals, okay? So lots of people are involved in achieving each goal for the stroke survivor. But all of us try to use evidence-based practice, so the research evidence, clinical expertise, and your values to move things forward. Goals are super messy, okay? So if Yasmin wants to return to having a coffee with friends, the doctors and nurses may help keep her health stable. The speechy may help her speak clearly and swallow safely. The OT may help her get ready to go out, so showering, dressing, those sorts of things, and maybe supply some useful equipment. The physio might help her to get to the cafe. The social worker helps with services, so maybe the NDIS or some support workers. Friends and family will help with practice and go to the cafe. And the cafe and council, well, they've been encouraged to increasingly make environments more accessible. So you can see, it's not just me that's going to get Yasmin having coffee with her friends, it's all of us. Okay, so down the bottom, I think that actually says Patient Journey Acute Hospital. So that's where it all starts. Some of these things that I'll discuss in each step may occur at different points of your journey. These are just a few examples. So a speech pathologist in acute setting may work with doctors on a differential diagnosis, because sometimes if the communication impairment doesn't match up with what the diagnosis is, they may do another scan of the brain. They work with nursing, so to do the swallow screening that you might have had. You might have heard of the assist. You might have been nil by mouth before seeing a speech pathologist. Speech pathologists may work with dietitians and doctors. So if you can't eat food safely through your mouth, you might have a tube that you consume through. We work with pharmacy on medication safety. So if you're on a modified diet, you might not actually be able to have certain medications because we can't crush them all. And we work with families and the team. So we screen your communication and then we provide some strategies to help you communicate with everybody. Okay, and this one is rehabilitation, when we get to rehab. So again, speech pathologists may work with patients, family and friends to set goals, provide education and bring you into therapy. The dietitian and the diet aid to try to avoid malnutrition, because if we're on a modified diet and thicker fluids, we're at increased risk. And they might help provide aphasia-friendly menus, okay? So some with pictures that make it easier to understand. We may work with a music therapist, so a melodic intonation therapy to try to get some sounds and words coming back. Or an occupational therapist. So for example, we might go into the therapy kitchen with our occupational therapy colleagues and work on word finding in the kitchenette while we're working on preparing a cup of tea. We also, I think like most of us, do a little bit of cognitive, so thinking, screening and therapy. We may work with the physios and the exercise physiologists to help with the instructions in the gym and also to make sure we've got the right drinks in the gym so drinks don't go down the wrong way. And then we work with social work and psychology to help communication access, so being able to understand and be understood when we get our counselling. Just keeps going, doesn't it? So we also work with nursing staff to help with mealtime strategies and volunteers on how to help involve the patients in diversional therapy. So I say it goes on, but that's because we do so much collaboration. It's so very important. And then when we get into the community, the speech pathologist is still there as part of the team. So again, we might work with the occupational therapist to prescribe and mount augmentative and alternative communication systems. So if, for example, a stroke survivor needs an iPad to help communicate, but they're also in a chair, we'll work together to get that mounted, okay? You can also see there a personal alarm. So if you can't communicate over the phone, well, that will communicate for you. Call emergency services. Now, at Royal Rehab, there's a sexuality service and there's a speech pathologist working there as part of the multidisciplinary team. Okay, so there they help with saliva management and also communication to help improve confidence, dating and intimacy. So really important. We also work with workplaces and education, so like TAFE and universities, to help adapt tasks to communication needs. Now, it's obviously not just us doing that. There are services like Job Access and other people involved, but we're definitely part of the mix. And then we also work with your GP, the NDIS, so the National Disability Insurance Scheme, and My Aged Care, okay? So just to help support our recommendations along the way, monitor your communication and swallowing and review how things are going. Speech pathologists also work with government and community groups. So advocacy to government, for example, to have thickened fluids included in the NDIS. We train, so I was involved in training the Regional Assessment Service who conduct some of the My Aged Care assessments. And education, so doing things like this. Nice and short, speech pathologists are part of multidisciplinary teams. We work with stroke survivors in acute, rehabilitation and community settings. Primarily, we help improve communication and swallowing outcomes, and we may be able to help someone, well, to help you or someone who you know. And if that's the case, you can always contact me. You can contact Metro Rehab on the number provided, Royal Rehab that includes that sexuality service that I was talking about, or find a local speech pathologist in your area if we're a bit hard to get to. And you can do that through the Speech Pathology Australia website. That's it. Thanks so much for your time.
Thank you, Virginia. We're now going to have questions, and if you're an online attendee, please post any of your questions in the chat box on your screen, and we are going to open up the room for questions to our guest speakers. But I'd actually like to take the opportunity to ask the first question, if possible. My question is around when a stroke survivor is going home from whatever setting, and that family meeting, discharge planning is so important. So as a multidisciplinary team, how do you all collaborate together to get it happening correctly and so that it all happens well? And do we have a mic? Yes, we do. Yeah. Who'd like to answer that?
Okay, I suppose I'll go first. So at Metro Rehab Hospital, we're very fortunate to have a very experienced multidisciplinary team. Now, predominantly it comes down to the social worker, or myself as the care coordinator, to organise these family meetings. Everybody participates, so the stroke survivor is there, their representatives are there, the rehabilitation specialist and all members of the team. But it's a lot of information all at once, isn't it? So one of my roles is actually to provide a little bit of a summary afterwards. So I have a chat with the stroke survivor and their family, answer any questions, but it doesn't stop there. So there may be questions after the fact, and I'm happy to answer those as well.
Thank you.
I guess the other thing to add in terms of your question about how we all kind of collaborate beforehand would be throughout the week. We have team meetings, case conferences, we do goal setting with our patients. So usually by the time, at least in my experience, when we all come to the family meeting, we usually know our patient really well and have come up with a good plan already, and it's just an opportunity to all be in the one space together and discuss it as a whole team. So I think often when we get there, we are all already have done all that planning through those other meetings and that collaboration already with our patients. Did you want to add anything?
Well, I think we usually having a little bit of briefing before meeting the family.
Yeah.
So make sure everyone on the same page.
Yes.
So we deliver the same message to the family to avoid any of the conflict informations.
Don't have anything terribly new to add there. It's a bit like a family meal. We've all got our own particular perspective on things. We're all throwing out. This is my version of what's most relevant, most important. We're probably a little bit familiar with what our colleagues have to say because we've been through that journey together. It's just a chance for us to share the important bits as we see them.
Thank you very much for that. I think do we take the online question next? And then I understand.
So to the panel in general, what do you find the most difficult part about working with other allied health professionals as part of a multidisciplinary team?
As I'm holding on to the microphone, I can be the first one to speak. The patient fatigue, and also I think the other things is the time. Everyone trying to fight for the patient on the same time as our working hour is the same, literally. So that's probably one of the biggest problems working with as a team. I often come across with a scenario is making the patient very, very tired, fatigued, before our dear speech pathologist come and assess the patient. And it's turned out the patient didn't have any energy to try the swallowing.
I think you're spot on. Trying to find the time for the patients to timetable everyone in and have the energy to participate in everything is probably the number one. I think because we work so closely in rehab, I think usually the teams know each other's roles really well. We've often worked together for a long time, so I don't think in terms of that you might see in other settings where staff rotate quicker or you have less experienced therapists, then maybe there's not as much understanding of the roles, but I think in rehab we kind of know each other really well and work together really well generally.
Yeah. And Sumitha, you're online. Do you have anything you'd like to say to that?
So as a rehab physician, we look at all the therapists together as one, and each one comes up with the plan. Sometimes it's a bit difficult. From my practice, what I've noticed is a goal from a physio-oriented or an OT-oriented or a speech-oriented, and then trying to put everything together, what to give importance to and what is actually really needed for the patient based on the medical background for that patient is something I do struggle now and then. So when we have the case conferences, we have a lot of discussion, and I need to be neutral, sitting back and looking at all my therapists as same. And when they come up with, I ask them to reason out why this particular thing. And that's something I still struggle, because some therapists are very passionate and everyone is actually good, want to do the best for the patient, but it's something as a rehab physician sitting back and looking as a whole thing, and the patient is admitted under my care and I'm responsible in the end. So trying to get that balance right and also keep my staff happy, I sometimes struggle, but yeah, that's I think part of my role, I think. Yeah.
Can you all please I want to say thank you to Sumitha, Andrew, May, Kate and Virginia. And can you please all thank them?